All right. Well, thank you very much. We are in the Syllabi fireside conversation with the founders of Repair, Murat Topors and Reason, right? So thank you very much for joining us today. And probably before we start, I want to ask you if you can introduce yourself. What is your role in the company, motivations to start these organizations, etc. Do you want to
Well,
start, Reason, please?
yeah. So so one day I woke up and decided I didn't want to die, and that's sort of the origin story. But that was some time ago. In terms of why I ended up starting a company rather than doing anything else, I did a lot of publishing along the way, a lot of patient advocacy, and that led me to know a lot of the people in the space. And when it made the jump from raising funds for research to raising funds for the first company, then I met a bunch of investors because they were people who were already putting money into the research side of things with their disposable capital. And that way I met my co-founder, and he talked me into starting a company rather than continuing just to be a patient advocate and sort of talking up the space and helping people move along. And that's kind of how I ended up doing that. And once you start a company, you go in with a few ideas, and of course, where you end up is not where you start. We encountered our present major program somewhat after we started the company, and have been working on it for 5 years now, I think, just about.
5 years, excellent. Thank you very much, Reason. Murat?
Yeah, so I'm more from the academic background. I did my graduate studies, I did my postgraduate studies, and then I was fortunate enough to land a full-time faculty position, and I had my own lab. This was at the Harvard Medical School in Boston. I spearheaded my own program for about 10 years. During this time, I was also a group leader for our drug development program at Pfizer. So I got to experience both the academic research side, but also the industry and commercial side of how to develop drugs. And around that time, the academic scientists, plight is always writing grants all the time and looking for money to do novel things, and it was all very, very interesting. But around that time, I was introduced to Reason and Bill, who are Bill Sherman, who are the co-founders of Repair Biotechnologies, by my friend and colleague Richard Honkanen, who is the chief of biochemistry at the University of South Alabama. He had tried to recruit me to go and join his department for some time, and then we had remained friends. And he contacted me and he told me about Repair Biotechnologies. And I was very intrigued by their approach. And I've been in my role as Chief Scientific Officer at Repair Biotechnologies ever since. So that's how I got into Repair, and I've been happy since.
And you have already gained an incredible reputation, Repair Biotechnology. So excellent. They have the right people. And listen, I have some questions for you, and maybe we can go one by one. The first one is most coronary artery disease therapies treat the symptoms or manage risk factors, right? That's what we have so far now with the statins and other compounds. What is the case for going after the root causes like vascular aging, and how are you in Repair Biotechnologies tackling it?
Well, I can answer the more general part of that, and then Morad, you can have a go at the specific side of that. That, I mean, the reason to go after root causes is that every time we've tried this, we generally, the human species, the results are much better than if you try to go after symptoms or manage the risk factors along the way. If you treat symptoms or manage risk factors, you get a reduction in incidence or a slowing in progression, or you can compensate in some way for the fact that you're horribly damaged, and therefore you get greater function than you would have done. But if you really actually want curative therapies and absolute complete prevention, you need to address the root causes. That's the only game in town if you want something that's better than what we currently do for most of age-related disease. And Morad, you can talk to the cholesterol and the importance of that in how we view things.
Right. And well, everyone is aware that too much cholesterol does put you at risk of atherosclerotic cardiovascular disease. So when your LDL cholesterol goes up, there is, of course, increased accumulation of cholesterol in your arteries. And of course, this causes larger plaques, which then of course become more and more of a problem, especially when they're vulnerable and they could rupture and lead to a heart attack or stroke. Now, all of the existing therapies basically slow down the progression of atherosclerotic plaque. When we are young, we have very little atherosclerotic plaque, or if any. But as we get older, there's increased deposition of cholesterol and in the certain sites of the blood vessels, and that causes atherosclerotic plaque. Now, all the therapies that exist right now, whether they be statins, PCSK9 inhibitors, what they do is they slow down the progression of atherosclerotic plaque. They don't remove it completely. So whatever you have at a certain point is only going to be the increase in that amount of plaque is only going to be slowed down by actually going on these therapies. What we do is very, very different. We want to actually regress the plaque and eliminate it. That's where we are very different in terms of our approach compared to what exists today.
And the important part here from the perspective of cholesterol is that we go after cholesterol inside cells. Specifically the excess cholesterol that's actually toxic to cells because they can't really deal with it very well. And wherever you have locally too much cholesterol in your body, you have too much of this toxic cholesterol, and that this is what happens inside a fatty liver. It's a major contribution to every way in which obesity makes various diseases around the body worse. It's important in neurodegenerative disease and so on and so forth. We really think of this as a hallmark of aging. One of the hallmarks of aging is that throughout your body, you're gaining more excess cholesterol in some locations. Obviously, more locations if you get overweight than if you stay thin, but it's going to happen to you anyway. And this is an important target to get rid of, as we are demonstrating with our results in preclinical animal studies.
That's right. And I should also add that what we're doing, our therapy, what it does is that not only does it degrade the intracellular free cholesterol that's causing this damage, but it also unravels our innate ability to regress plaque. Like, for instance, when we're young, we could actually regress the plaque, and that's why our arteries remain stable over time. But as we age, the accumulation of this free cholesterol inside the cells also hinders mechanisms of plaque regression. And so what we're doing is by getting rid of that excess free cholesterol, we're also restoring our ability to regress plaque and restore healthy arteries.
So that means that if it happens when we are younger, this inability to remove the cholesterol from inside the cells is something that is acquired with aging.
That's correct. That's correct. Yeah. As this free cholesterol accumulates in cells, it hinders our innate ability to remove the plaque. As plaque, there is a balance, right? There is plaque progression and there's plaque regression in our bodies as we're getting older. But as we get older, the excess accumulation of free cholesterol hinders the ability to remove the plaque, while the ability to stack more and more plaque gets even more accelerated. So what we're doing is we're actually we're restoring health to the cell, homeostasis, and the cells are then removing the plaque much, much faster. And you're going to have an artery that's much more healthy.
I can just imagine.
The entire industry is focused on mechanisms of plaque growth, and if you get rid of them, that's fine. You're hampering plaque growth, but you're not helping the mechanisms of plaque regression. So far as we know, we're the only group that's found a way to actually fire up those mechanisms of plaque regression. I mean, to the point at which it strongly outweighs any mechanisms of plaque growth that are going on.
This may take me to something that I read on your documents. Can you explain what is the role of thymic regeneration or immune system rejuvenation? Right, probably it goes with it. And what is the role it might play in cardiovascular disease prevention or progression?
So at the very high level, and I'll just tee this off for Morad to talk in more detail. The very high level, so your immune system just becomes gunked up with broken cells and bad little subpopulations that are doing bad things, and cells that are malfunctioning as you go forward in time. And you really have two very separate problems going on here. One is what's going on in the adaptive immune system, T cells largely. And the other is what's going on in your innate immune system, by which we might think here in this context of macrophages, because they're the cells that are sitting there in plaque, trying and failing to repair it. And as you go forward, both of these compartments are becoming increasingly terrible. And people have demonstrated that if you go in there and rejuvenate the thymus, okay, so you're making more T cells, that lets the body stop holding on to some of the bad T cells. If you can clear out macrophages, the body very quickly makes new ones, and those new ones, even in late life in animal models, they have few of the problems that the old ones have. So periodic clearance of the innate immune system is probably actually a good thing to do at some point when the medical community gets around to really doing that in earnest. But the meta sort of picture here that I think that Morad would be able to talk about more extensively than I is you reduce inflammation. Atherosclerosis is a disease driven by inflammation. Inflammation is a consequence of immune system aging, and you can say that at the high level, and then we could spend the next 3 hours talking about little individual contributions to that. But Morad, if you want to riff on that point.
Yeah, so inflammation drives the progression of atherosclerosis. That's been documented over and over again, and it makes a lot of sense. Now, one of the sort of mechanisms that actually are affected is the ability of the macrophages to pump out the excess free cholesterol onto HDL particles so that those particles could come back to the liver, and then the liver could get rid of the excess free cholesterol. That's the reverse cholesterol transport mechanism. Well, when macrophages are inflamed and they accumulate too much cholesterol, they become engorged, and they don't properly pass off this cholesterol, and therefore the progression of atherosclerosis is accelerated. What we do at Repair Biotechnologies is that we aid the macrophage to pass off that excess free cholesterol, thereby restoring immune function, and thereby bringing more of the free cholesterol back to the liver where we degrade it. Okay, that's our contribution in terms of the macrophage dysfunction. But at the same time, what happens, what we have found is that the immune system is reprogrammed. When we start degrading this excess free cholesterol, the immune system becomes more anti-inflammatory and pro-repair versus the pro-inflammatory mechanisms that are at play when we are building plaque. So we have found very new and perhaps previously unrecognized mechanisms at play here when we unravel these mechanisms of plaque regression.
That's fascinating. That's what I was going to say, to understand this biology.
Yeah.
And how close do you think we are? I mean, because I think that you are the leaders in trying to reverse arterial stiffening and plaque buildup. How close do you think we are to really clinically reverse? Because this is something that, when I went to medical school in the late 80s, early 90s, we were already talking about that, right? I mean, is it possible, et cetera? How close do you think we are?
Well, I mean, if you give us infinite money, we're in clinical trials like a year from now. That's just the way of it. So, and then apply the usual number of years it takes to plow through the rest of the regulatory process and get this out there, and into widening support from pharma and all that. So we're a late preclinical, early clinical stage company, and it takes time to get these things. But when you said arterial stiffening, there's something to be said there about that. So the stiffening of arteries is a distinct thing from atherosclerosis, atherosclerotic cardiovascular disease. So there's several fellow travelers going along here at the same time. There's the manufacture of this plaque that grows in your artery walls and messes everything up. There's the fact that your arteries are getting stiffer. And third, there's calcification. And all of these things tend to be fellow travelers because, hey, everything's messing up. You're getting older. You're going to have a contribution to all of these distinct processes, and they do feed into each other. Arterial stiffening does, increase the chances of atherosclerosis occurring, if only because it's increasing your blood pressure, which causes turbulent flow, which harms the blood vessel walls, and so on and so forth. But they are different things, and they have to be addressed in different ways. If you get rid of one of them, the others will become modestly less terrible. But they are very different things. I mean, Morad, do you want to add to that?
Yeah, I want to, in terms of our landscape of how quickly we could get this out there, we are sort of hindered by the general consensus that plaque regression doesn't matter, right? Everybody is focused on lowering lipids. Let's lower LDL cholesterol. Let's lower triglycerides. Yes, those therapies and that kind of thinking and the therapies that exist right now will, as I mentioned at the outset, will slow down the progression of atherosclerotic plaque. But these patients do not actively regress their plaque. Yes, there are a few patients where you see some plaque regression when there are aggressive lipid-lowering therapies, but in general, we don't get any regression of plaque. And because of that, people have always used as surrogate marker LDL cholesterol or triglycerides or any other lipid biomarker to say that this drug is working and therefore let's move on. And so the FDA right now does not recognize plaque regression as a meaningful endpoint, okay, for most clinical trials, because they haven't done any clinical trials on that. But there are meta-analyses that show that just a regression of only 1% can have an effect of almost reducing to reduce major adverse cardiovascular events by 25%. So just by regressing the plaque by 1%, right?
You mean
That's
1% the size of the plaque?
the percent atheroma volume. If you could just regress
That's
by
it.
1%,
Okay.
then you could have a benefit of reducing major adverse cardiovascular events and death by 25%.
25%.
That's a huge effect, right? So in our models, we achieve plaque regression of like 25%, 30%. If we could do this in humans, that's an end to cardiovascular disease.
Yeah.
You're not going to have death due to plaque rupture or cardiovascular disease. So that's what we're aiming for. But because there are these obstacles where the FDA still does not recognize plaque regression as a meaningful as a pivotal endpoint, it will of course lengthen our time until we actually get approval. But there is, of course, there's change in the air. There are more and more advocates that are recognizing the importance of plaque regression, and some of them are on our advisory board at this point. Dr. Ronald Cosberg, Dr. Deepak Bhatt, they both prominent cardiologists and very well-known cardiologists recognize the value of plaque regression. And the reason why people haven't recognized this so far is because none of the drugs can meaningfully regress plaque, but they can change lipid levels in the blood.
Yeah. So I'm going to add one thing about arterial stiffening, which is I think for my money, hypertension and stiffness of arteries is the most successful area of medicine in which people have failed to do anything about the causes of the problem. It is the triumph of compensation and forcing compliance in your blood vessels through mechanisms that have nothing to do with why it's a problem in the first place, because researchers have found the regulators of smooth muscle, they've found the regulators of blood pressure, and you use small molecule drugs to put a big thumb on the scales, and lo and behold, you lower blood pressure. And for the people that can tolerate the side effects or have minimal side effects, the vast range of antihypertensive drugs are very effective. And they reduce, and if you control your hypertension, which most people can do through some combination of these drugs, many of which are very cheap now, then you get something like a 20% reduction in mortality risk. And that is what triumph looks like when you fail to address the causes of the problem. Ultimately, at some point, obviously, you get old enough and your system gets messed up enough that the drugs stop working, or you die of other causes first, or your cardiovascular system goes beyond the ability of the drugs to compensate for. But dealing with hypertension and stiffness, that's a triumph of modern medicine writ large, and it illustrates, what is the outer bound of how far you can go without actually addressing the root cause.
Yeah, that's very true. The numbers that you're giving me are very encouraging. Basically, my reading is that if you're successful, and hopefully you are successful in clinical trials, in human trials, well, this will be probably one of the most disruptive therapies in the history of modern medicine, right? I mean, and I say that because of the frequency of and the mortality of coronary artery disease. The fact that you can reduce MACE to that level just with that small reduction is really incredible. Now, I know that some companies are pursuing, plaque regression in many ways using mTOR, the elimination of senescent cells, And of course, lipid metabolism. Which mechanism do you think will matter most in solving coronary artery disease in the long term? Or is a
Oh,
combination of many, or what do you think?
if I knew that, I'd be placing probably much better investment than
Good
than
answer.
I have been historically, right? So
Got
this
it.
is really fascinating thing about the field here is that if you just move away from what's popular
Mhm.
and just look at what's out there in the research, what people have done at some point over the last 10 to 20 years in the lab and has not yet sort of made it as far as major investment into for-profit development. There is a lot. There is a lot when it comes to how do you slow plaque. People are doing all sorts of things. And the fascinating thing is, they all kind of work to slow plaque in mice, and there's a handful of things that show some regression in mice, not all of which will make good drugs or could ever possibly be made into drugs. But if you're really interested in competing with, LP little a or LDL lowering or PCSK9 inhibitors or whatever is out there right now, you have a lot of choices. But it's very hard to say. The point I wanted to make there, it's very hard to say, will any of these be like 10% better or 50% better or like, 50% worse than the current options. We have absolutely no idea what LP little a lowering is going to do relative to LDL lowering. People are really enthused by this because any pharma entity that looks at a new circulating marker that you can lower with a small molecule drug and maybe you get a new statin, they don't see that as a failure. That you failed to do better. They see that as dollar, 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 dollar. That's their view of it. We live in a very incremental field, but I think that very long way of saying there's a lot out there and we have no idea how well they're all going to do.
Yeah.
But so far as I know, we are the only people who found a way to produce very large, very rapid plaque regression. We're the only people who's touching on the important mechanism, I think. So Morad, feel free to elaborate.
Yeah, I'd like to elaborate on that. I think that when we're looking at plaque regression, we really have to be careful, right? Because there is a mass now in our arteries that is full of lipids, and the more vulnerable, the more prone it is to rupturing, the more likely you're going to have a stroke or a heart attack. And so what we want to do is when we're regressing our plaque, we are very mindful of the fact that we are not only regressing the plaque slowly and in a measured way, meaning that not only are we shrinking the plaque, but we're also stabilizing the plaque. And a fibrous plaque is an asymptomatic plaque. The more fibrous it is, the more solid it is, the less likely it is to rupture and cause, very adverse and potentially lethal effects. So when we look at senescent cells, you have to target them and you have to make sure that you're targeting these cells very carefully, because some of these cells actually, not only do they contribute, of course, to the inflammation around the plaque, but they also provide support. So you don't want to regress the plaque while making it very, very unstable and then making matters worse. We are very fortunate that our mechanism of action also causes collagen deposition and other extracellular matrix onto the plaque that makes it stiffer while it's regressing. So that from that aspect, we are quite fortunate about that.
That's excellent. Excellent. Yeah, I would agree with you. And listen, I really wish you the best because I think that you're doing something very innovative, disruptive with already excellent results, and hopefully you're successful. My last question for you is, do you have any advice to young scientists or founders trying to build age-reversing therapies in this field that is dominated by risk-averse, symptom-oriented thinking? Any advice for them?
Well, I think the first advice would be wait for the next up market. The last up market and enthusiasm in longevity, wow, that was a wild ride. And a lot of people got funded with that enthusiasm. And right now we're in kind of a retrenchment until the first therapies, I think, get approved. But once that's happened, it's going to be a real takeoff scenario. There's going to be if you think that a lot of money is going to it now, wait to see what happens once the first therapies are out there and people really understand that this is a field in which you can just go in there and actually help people live longer and reduce all of their age-related diseases. if you're starting your company now and you have to, well, I wish you luck. It's a tough market out there. Go find the high net worths. They're the most likely to help. Morad, any thoughts beyond that?
Yeah, and if you're thinking about ideas, think outside the box. A lot of the literature out there makes us think in silos. But and what we found in Repair Biotechnologies, because we try to always push the envelope and think outside the box, we find that some of the mechanisms that people thought and they took for granted were, not very meaningful, or at least maybe wrong. And so, you could come up with new ideas, new concepts. So always keep an open mind, and what they say, slay your heroes. Like, try to do the best you can do while thinking outside the box. And as long as, of course, you could raise money. And I think that point that Reason raised is very, very important. This time is not a great market, but we do our best to stay the course.
Excellent, excellent. Morad, Reason, thank you very much for your insights. It's really an inspiration to hear you speaking. Let's stay in touch, and again, we wish you the best for the sake of your organization, and especially thousands, millions, hundreds of millions of patients suffering with coronary artery disease. So thank you very much for your time.
Thank you.
Thank you.
Thank you.
Thank you. Excellent. Thank you. I think this was great. I loved it. Wonderful. I loved it. I think that you have the right messages. You were fair, data oriented. I loved it. So we're going to work on some specific sections of it to remark them in a short 2 or 3 minute video. And we'll send it to you. Give us a couple of weeks to work on that, and we'll send it to you.
Great. Thank you both. Thank you very much.
Yeah,
Thank you, guys. Bye-bye.
Bye-bye now.
Thank you.